Our next speaker is João Gustavo dos Anjos Morais Oliveira from Brazil. He's from the Escola Bahiana de Medicina e Saúde Pública. And he'll talk to us about the endocannabinoid system and its role in neuropathic pain. I would just like to mention that João is in a bit of a rush, so he would not be able to take any questions. So he has to leave right after his talk. So no further delays, João, the floor is yours.
Hello, everyone. Thank you, Srikanth. My name is João Gustavo Oliveira. I'm a 30-year medical student from Brazil. And today I'm here to present this part of work I've been doing with my group. I put their names here because they are so special to me. And it is entitled The Endocannabinoid System as an Alternative Way for Neuropathic Pain Treatment. Since in this presentation I will cite treatments and medication names, I'll have to declare that I have no conflict of interest here. And so before we start, understanding which treatments are being used for neuropathic pain treatment and its efficacies, I would like to introduce some concepts that may make this talk easier to everyone. First of all, what is the endocannabinoid system? So the endocannabinoid system is a group of receptors, molecules, and enzymes that can be responsible for its biosynthesis and degradation. The name of the system comes from the fact that these molecules, these primary molecules, are endogenous and they have some structural similarity to the cannabis sativa molecules like THC and CBD. Also, those molecules are called the 2-AG and anandamides primarily. The 2-AG or 2-acylglycerol, and the anandamides is called as well the arachidonyl ethanolamide. They are both icosanoids, which are synthesized on demand by those enzymes. In the case of the 2-AG, it is synthesized primarily by the diacylglycerol lipase, and the anandamide is synthesized primarily by the N-acyltransferase and the phospholipase D. They are removed from their sites and then taken by uptake processes and metabolized mainly in monoacylglycerol lipase and fatty acids amides hydrolase in case of the anandamides. This structural similarity that I talked about, it's why we can use products of the cannabis such as artificial products like CT3 and other agilamic acids and as well for the agonism of these receptors because they have some similarity on their structure. In fact, the receptors in the timeline were the first one discovered, and then the molecules that can agonize these receptors were discovered in the timeline. So these receptors are primarily two, the CB1R and the CB2R. They are distributed in different forms in our central nervous system and as well in other tissues. In fact, in this image from Fraguas Sanchez 2018, we can see that CB1R is predominant in this central nervous system, but it can be found also in peripheral nerve terminals and other neuronal tissues such as stomach, sexual organs, vascular endothelium, among others. The CB2 receptors, they are mainly located in the immune system, but they can be found in the central nervous system, as we can see. In fact, in the limbic system, there are lack of evidence, but we can see it being expressed in the dorsal horn of the spinal cord and in the periphery of the nervous system. In fact, these receptors are inhibitory G protein coupled receptors, which regulates the adenylate cyclase and MAPK signaling pathways. It means that they can inhibit the calcium influx on the presynaptic CB1 receptor activation and thereby reduction of nociceptive transmission. That's important because they will not be, these presynaptic neurons will not be able to release those neurotransmitters associated with nociceptive transmissions, such as glutamates, GABA, and other ones. The CB2R functions just like the CB1R, but it can also decrease the release of pro-inflammatory cytokines. In this image, we can see as well that the CB1R is important in very process on the nociceptive transmission reduction. So when we are talking about the spinal cord level, the CB1R is responsible to inhibit the ascending of the nociceptive transmission. That means that the nociceptive transmission through the spinal thalamic threads and the pain processes associated with the dorsal horn of the spinal cord and the spinal cord dorsal ganglion are suppressed. It can also activate in a supraspinal level the sending inhibitory pathways that can come from the periaquedutal gray matter and the nucleohalphus magnus, and they can modulate as well. Also, the CB1R is associated with the modification of the affective components of the pain, so it can be found in the limbic system as well. And you might be thinking now, which conditions cause the neuropathic pain? Well, the neuropathic pain is associated with neurons and immune cells, which are sensitized by signaling substances such as nerve growth factors, cytokines, and they become pharmacologically dysfunctional and hyperexcitable. That means that they can conduct pain easier, but they are not responding as so good to our pharmacs, to our medications. And some conditions can cause that, such as HIV, the virus, which causes the AIDS, the immunodeficiency syndrome, the multiple sclerosis, trauma, not only trauma of brachial plexus or lumbosacral plexus, but trauma from the spinal cord as well. And cancer can cause this condition of neuropathic pain. It's normally a chronic pain, not an acute pain, and that's why we have to look forward for some new treatments for it. So going on are some evidence that we have collected to now. I divided some topics to discuss. So first of all, a question that has been made a lot is solitary or combined administration. In fact, there are no conclusive comparative studies for that. There are no study that compare the use of the combined administration to a solitary administration of any cannabinoid at all. But there are and as well, there are no difference efficacy between those cannabinoids, between THC to CBD, CT3, and other synthetic. Between studies, it seems that the combination have more benefits because the combination of THC and CBD, for example, it's good to reduce some adverse effects that can be present in solitary administration. Another topic that I like to talk about is the smoke cannabis cigarettes daily administration. So in mixed neuropathic pain, it improves spontaneous relief, but have not altered stimulus evoked pain. That's important. Some conditions have lots of difference between their responsibility to this treatment. And with doses of 3.56% of delta-9 THC, there were pain relief in patients with sensory neuropathy from HIV. In fact, this 3.5% was administered 3 times a day for a short period of 2 weeks. And cigarettes with lower 1.29% and higher 7% content of delta-9 THC shown similar efficacy. So the dose is not very well pointed. In post-traumatic or post-surgical neuropathy, cigarettes with less than 9.4% of delta-9 THC contents produced no significant pain relief. So we see that probably there are more conditions that will have necessarily more those up higher. So The vapor inhaled administration, we see that in nabiximols, a combination of THC and CBD, was used in vaporization devices and showed efficacy for multiple sclerosis. That's interesting because nabiximols, it's called as well as Sativex as in a commercial use, and it was the first cannabinoids medication approved in some places of the world. But it is normally used as an oral mucosal spray. But here it was used in a vapor inhaled administration and has shown some efficacy as well. There are new vaporization devices that can hit the plant material, releasing the active phytocannabinoids. That's interesting because it's better than the use of the smoked cannabis because it won't produce the carbon combustion harmful compounds. The studies evaluating inhaled cannabis did it for short duration, and that's probably a good critic because we don't have any studies taking a long-term duration. Sublingual spray administration of delta-9 THC and CBD, combination in a range of 2.5 and 120 milligrams a day was effectively analgesic in the case of the oral mucosal administration. The sublingual administration was primarily made with Sativex, the nabiximol I already cited, but there was another combinations that was used with different concentrations of THC and CBD. So this study is primarily not as well conclusive. There are studies showing no advantage of nabiximols over placebo in pain relief, but in other conditions. Those troches lozengos are indicated satisfactory pain relief in multiple organs of neuropathic pain, but those troches are okay. Those troches are formulated with different concentrations of CBD and THC. In the case of oral administration, the use of dronabinol capsules 2.2 to 10 milligrams a day showed pain reduction in patients with MS and spinal cord trauma. The nabilone in lower doses was effective in chronic open motor neuron in DPN, the diabetic peripheral neuropathy, and the azulamic acid CT3 was good to lower pain and had no major adverse effects in a different concentration between 7 days. We have other associations and treatments, so the cannabis can be associated with opioids and lower pain in several conditions. They can be associated with opioids and dronabinol, a synthetic delta-9 THC, orally that lower pain in oncologic patients, and preclinical students have provided good evidence of endocannabinoid degrading enzyme inhibitors, but in clinical studies, those inhibitors failed to produce any significant anti-nociceptive effects over the placebo. And in a trial for a fatty acid amide hydrolase inhibitor, the Bayer 10-24-74, there were catastrophic results with severe deaths and the death of one volunteer. The adverse effects are a lot. The primary severe are those three ones. And for our conclusion, I have to say that preclinical tests are not effective on the evaluation since they only evaluation hyperalgesia and allodynia, and more clinical trials are needed. There are still worries about the chronic use. This might be associated with some society taboo with the cannabis sativa. And even though nabiximols is approved in many countries, there are still a long road to travel in a lot of countries, including my own. Thank you for your attention. My name is João Gustavo again. My email is here, so you can contact me for any questions.
Right. Thanks, João. But I guess you have to leave, or do you have a couple of minutes left?
Let me see. Oh, sorry. It's already my time. If anyone have any questions, do anyone have? You can send to my email, please.
Well, I have some questions, but I'll email you later.
Okay, thank you so much.
Okay, great. Thanks. Bye.